Yes, who is going to tell me the definition of glaucoma? बताइए. Irreversible change of visual field. Wait. Irreversible change of visual field. Before that, उसके पहले, last time I told you how will it define? It is a, हाँ, sorry, फिर से बोलो. Okay, anybody who can refine? Yes, please sit down.
Progressive optic neuropathy with increase in intraocular pressure.
अभी बोला ना, increase नहीं with तो without, हाँ. Okay. So nobody will say rise in IOP is glaucoma. Okay, ये कभी नहीं बोलना कि rise in IOP is glaucoma. That is what I want to stress. Okay, so glaucoma is chronic progressive optic neuropathy. ठीक है, ये समझ लीजिए. It is a chronic. When you start saying it's, you say glaucoma is defined as a chronic progressive optic neuropathy, which is associated with the typical changes at the optic nerve head, with retinal nerve fiber layer loss, with corresponding visual field defects. ये आपको बोलना है. Start नहीं बोलना है कि irreversible visual field defect is glaucoma, है ना. Visual field defect यहाँ का because of many conditions. Neurological disorder में hemenopia होता है ना. So don't start like this. It is a irreversible visual field damage. It is a chronic progressive optic neuropathy with changes seen in optic nerve head, है ना, with the retinal nerve fiber layer defects and corresponding visual field defects. Whatever structural changes occur here, you said similar defects in the visual field based on the optic neuropathy. And IOP is an important risk factor which may or may not be high in glaucoma. Like, can you give an example where IOP remains normal but there is a glaucoma? Can you give an example? Sorry, which type of glaucoma I am asking you? Normal tension glaucoma, okay. Because there can be glaucoma where IOP is normal, but still there are changes of optic neuropathy, glaucomatous optic neuropathy, okay. That was a normal tension glaucoma. Or another term is where IOP is high, but there is no any optic neuropathy. What is that known as? Ocular hypertension. That is not labeled as glaucoma. IOP may be 26, you won't label it as glaucoma. Try and understand this. Okay, IOP may be 26 millimeter of mercury, may be 28, but provided the central corneal thickness is normal. I told you CCT is high, it may give a wrong high reading. Okay, so if you record IOP of 26, 28 in any of the patient, don't label as glaucoma or don't diagnose as ocular hypertension unless central corneal thickness is measured. Suppose CCT is 600. Normally I told you how much is the CCT, central corneal thickness? What is normal central corneal thickness? I told you in last lecture, around 520 to 540 microns is the normal corneal thickness. Suppose cornea is 600 or 620 microns thick. So when we record the IOP, we record by applanating or indenting the cornea. If cornea thicker, it will indent less, so it will record false high IOP. Okay, so there can be high IOP without any optic neuropathy. So we won't label it as glaucoma. We call it as ocular hypertension, high IOP. Okay, so try and understand this concept. So I will just revise whatever you have learned in the last lecture. It is a multifactorial because in normal tension glaucoma IOP remains normal, still there are optic neuropathy changes. Okay, so there are other factors like rightly he said vascular factors are there. Okay, the sleep apnea has been found to be associated with glaucomatous optic neuropathy in normal tension glaucoma patient. Acute blood loss, okay, or when there is a vascular dysregulation is there, normal IOP may be associated with a optic neuropathy. Okay, to understand these two terms, it is multifactorial disorder. There are other factors which are also playing, which are non-IOP dependent optic neuropathy. Okay, so normal tension glaucoma, you should know what is ocular hypertension, and rise in IOP is not glaucoma. It is this I told you how the optic nerve is formed by all the axons of the ganglionic cells. They form they exit from this scleral canal and form the optic nerve. So basic pathology in glaucoma is the death of the ganglionic cells of the retina. The basic pathology is death of the ganglionic cells in the retina, and these are the axons of the ganglionic cells which form the nerve fiber layer, which axons which pass from here, and there is a death of these axons giving rise to retrograde damage to the ganglionic cells, and therefore we see changes which are typically around the disc and around the peripapillary area in glaucoma. Okay, so you examine the disc and see what are the changes occurring which are very typical of glaucoma, which I am going to tell you in the future lectures. Okay. So, this is the basic concept regarding the glaucoma. Then I also told you it is a silent killer of vision. Why? Because, sorry, because it is asymptomatic. Okay. There are no symptoms of glaucoma. Okay. There are no symptoms of glaucoma. Patient will not come to you with any symptom. Then how do we diagnose it? By, sorry, by screening the patients. By screening the patient for glaucoma. Patient when come to you for any complaint, for refractive error, for glasses, for headache, dimness of vision, any complaint patient comes. So, we never send the patient by just doing refraction. Refraction vision may come 6 in glaucoma also. In advanced glaucoma also, it may be 6, there is a tubular vision in glaucoma. So, vision may improve to 6 does not mean that patient does not have glaucoma. So, to screen every patient coming to OPD for glaucoma, then only we can pick up glaucoma, otherwise we will miss glaucoma. Okay. So, I told you in last lecture, according to Chennai glaucoma study, 90% of glaucoma remains undiagnosed in India. Why? Because screening is not done. Comprehensive ocular examination of all patients coming to hospital is not done, and patients do not come for regular eye checkup also. There are two reasons. Patients are not aware that they should come regularly, yearly, 2 yearly for eye checkup without any complaints. Okay. And when they come for any complaint, it is the duty of the ophthalmologist to do a comprehensive ocular examination, especially the disc and IOP, to screen patient for glaucoma. Then only we can pick up glaucoma. Otherwise, patient come when they have lost vision completely in one eye. Then they realize I cannot see from this eye, so I should go to the for eye checkup. So, a regular eye checkup every 2 years, 1 year, 3 years is very, very important, because it is a slowly progressing disease. It does not become blind in one day. It is a very slowly progressing disease. It takes years for patient to become blind due to glaucoma, except in acute angle closure glaucoma. Correct? So, this much you should understand about glaucoma. I told you normal range of IOP 10 to 20 millimeters of mercury, there can be diurnal variation, highest IOP being in early morning. So, if the IOP is normal and you are seeing changes in optic neuropathy, do not say it is normal tension glaucoma unless we do diurnal variation. Okay. So, IOP is normal, one reading taken in the OPD, there is a glaucomatous optic neuropathy, do not label as normal tension glaucoma unless we do diurnal variation. Patient may be having peaks in the early morning. So, we admit the patient, we do every 2 hourly, 3 hourly IOP for 24 hours, make a chart and see how much fluctuations are there. What is the normal variation? How much should fluctuate? 5 millimeters, okay, not more than that. Okay, 5 millimeters, not more than that. If it is more than 8 or 10 millimeters fluctuating, from 16 it is going 26, it means it is not normal tension glaucoma, it is crossing the upper limit. So, it is a type of pulmonary open angle glaucoma. So, diurnal variation is very, very important in situations where you are diagnosing a normal tension glaucoma, or when you doubt that patient has normal IOP, but still there are changes in the optic nerve. Okay. So, there is the importance of doing diurnal variation test in patients with glaucoma. Then I told you about aqueous humor dynamics. What is the site of aqueous humor formation? Ciliary processes. Okay. So, pars plana, pars placata. So, pars placata has ciliary processes. So, from there the aqueous humor is secreted by the non-pigment epithelium of the ciliary body. Okay. And then it comes in the, this is the posterior chamber where it is get collected, comes in the, from the pupil in the anterior chamber, drained from, what is this called? Angle of anterior chamber, where there is like a trabecular meshwork. Okay. There is an angle of anterior chamber between the cornea and the root of the iris. So, in this recess there occurs trabecular mesh, which is sieve like structure. From there the aqueous is drained continuously, and this circulation maintains the normal intraocular pressure. Correct? So, from here it is formed by the, I told you there are 3 mechanisms: secretion, diffusion and ultrafiltration. Okay, secretion is an active process. From here it is formed and it is drained mainly from the trabecular meshwork, but there is one more pathway which is called unconventional pathway. 10 to 20% aqueous is drained from the uvascular outflow from the root of the ciliary body. Okay, so these are 2 outflow pathway. Then I told you about pathophysiology. What is the cause of optic neuropathy? Why there is a death of ganglionic cells? Why there is a death of retinal fiber layer? There are 2 theories. What are those? One is the mechanical theory, where there is a, when the fibers they pass to lamina cribrosa, because of the high pressure, there is a compression, mechanical damage to those nerve fibers. There is a disturbance of exoplasmic flow to the, through these axons of the ganglionic cells, which give rise to damage to the ganglionic cells. And second is the vascular theory, where there is a vascular dysregulation is there to the blood supply of the optic nerve head. or the nerve fibers, the axons of the ganglion cells which form the retinal nerve fiber layer. This is give rise to the optic neuropathy. This is mostly seen in normal tension glaucoma. I told you pressure is normal, but because there is a vascular dysregulation, genetically predisposed, it is a genetic disease. So, these patients may have because of this reason, like in Raynaud's phenomena, okay, when there is a migraine patient, we have vasospasm. So, there is a decreased flow, blood flow, or there is a nocturnal hypotension, patient taking, hypertensive patient taking tablet in the night, so the BP goes down, okay. So, that time there may be less blood supply to the optic nerve because of the vascular dysregulation. Sleep apnea giving rise to hypoxia, okay. So, there are many factors which are playing in normal tension glaucoma, where cause is vascular mainly. In high tension glaucoma, it is the mechanical theory. So, there are two theories to explain how the optic neuropathy occurs. Coming to the investigations, I told you we do comprehensive evaluation. Once you screen the patient, you suspect glaucoma, like IOP is high. Patient has come, you have done a routine IOP, you find it is 28, 26. So, you suspect glaucoma. It could be glaucoma, it could be ocular hypertension. So, you investigate the patient. Or you have done a routine fundus examination, you find the disc is looking suspicious of glaucoma. Changes are seen in the disc, so it could be glaucoma, though IOP is normal. So, again you will take this patient for detailed evaluation to rule out glaucoma or to diagnose glaucoma, correct. So, these are the investigations. We do tonometry to record the accurate IOP. Then we want to know the changes in the disc, so disc evaluation including fundus examination also. Then we do visual field to correlate the changes seen in the disc with the field changes, and we want to classify glaucoma, which type of glaucoma we are dealing with. Is it angle closure? It is a open angle glaucoma, because management differs, What you are doing? Taking notes? Okay. So, we have to do gonioscopy to examine the angle of endotome, because we want to differentiate between the angle closure and the open angle glaucoma, because the line of management is totally different from these two types of glaucoma. So, it is very important to do gonioscopy in each and every patient of glaucoma, but it is primary or secondary, or it is angle closure or open angle, okay. Very important investigation. Then I told you to know the accurate intraocular pressure, to do pachymetry, means recording the thickness of the cornea. So, that know whether it is a thinner cornea which will false low IOP, okay. So, it may give a false low IOP, patient may be having a higher IOP, and it may be a thicker cornea which is giving a false high IOP, correct. So, and I told you thinner cornea is an independent risk factor for glaucoma progression. So, it is important to know thickness in every patient of glaucoma, correct. Then I told you for quantitative evaluation we have optical coherence tomography, which can give you thickness in the microns. So, we can follow the patient, now patient after 1 year whether glaucoma is progressing or not. Once you are diagnosed, it is important to stop the progression of glaucoma. Okay. Once you are diagnosed, it is a glaucoma, started treatment, then these patients require a lifelong follow up, because we want to know it should not progress, we should not lose his vision, should not lose his ganglionic cells further once you have diagnosed glaucoma. So, how will you know? So, you have to follow the patient. So, we see the visual field serial every 6 months, 1 yearly, to see that the scotoma is increasing in size, or we record IOP to see that the IOP is well under control, and third is we will do OCT to see how many microns patient is further losing the thickness of the the retinal nerve fiber layer, okay, and neurotubular rim. So, these are the investigation done in a glaucoma to diagnose as well as to know the progression of the glaucoma. So, we have to counsel the patient to remain in follow up for whole life. Okay, once diagnosed, patient has to remain in follow up for whole life. Regular follow up is very important. So, here comes the importance of counseling, giving chair time to the patient. Okay. So, we have to, even in busy OPD of 300, 400, we have to select patient who requires more chair time, who requires more counseling. Okay. So, in glaucoma patient, you have to explain the disease to the patient, what disease he is suffering from, and then you have to explain that you have to come for regular follow up. So, coming to first innovation, that is tonometry, recording of intraocular pressure. So, first is digital tonometry, where you are trying to roughly assess the intraocular pressure with the help of your palpating the globe. Okay. This can be done in clinics, in bedside, anywhere. Okay. So, here what is done is you are just going to palpate the globe above the eyelid by placing 2 index finger just above the tarsal plate in the eyelid. Okay. So, ask the patient to look down, and just with your 2 index fingers we try to feel have the feel of the globe. It is stony hard, it is soft, or it is firm, correct. If IOP is very high, you will feel a eyeball is very stony hard. It is a rough estimation, it is not a very accurate, but many times like in patient with corneal ulcer, you cannot do tonometry, you cannot put tonometer over the cornea. In an immediate post-op period, you cannot put tonometer over the cornea. Patient with trauma, epithelial defect big in the cornea, you cannot record IOP with the tonometer. So in certain situations, you have to rely on digital tonometry. Like you people when come for clinics, you are supposed to do digital tonometry, not the instrumental tonometry. Okay, so it's very important to have a rough assessment of the intraocular pressure. So here, what we do with the help of 2 index fingers, ask me to look down and not over the tarsal plate, just above the tarsal plate have to go, and we have to just palpate the globe and feel the cornea, okay, and press the globe and try to have a feel. Normally, it will be firm to touch, okay. If it is very high, you find it is stony hard. Always compare with the other eye also. Always compare digital tonometer with the other eye also. If it is low, eyeball is very soft. 6 mm of mercury, 8, it will look very soft eyeball, okay. This is the rough estimate. Quick, easy, no cost involved, but tonometer is not available. You have gone bedside to see the patient, okay. Patients admitted with severe vomiting, nausea, headache, eye pain could be an acute angle closure attack. Admitted for some other diagnosis, very common with vomiting and headache, admitted in medicine. So you go and you have to do digital tonometry bedside to see whether eyeball is stony hard. Okay, acute angle closure eyeball will be around 50-60, so eyeball will appear very hard. So you can do bedside tonometry, or in patients who have just undergone any surgery, keratoplasty, or patients who have a corneal ulcer, you cannot do instrumental tonometry. So you rely on digital tonometry, and this is very important for you people. When you come to clinics, always record the intraocular pressure for rough estimate of the intraocular pressure. It's subjective. To you it may feel very firm, to you it may feel very hard. So it requires experience. When you palpate multiple times, then you will be able to judge. Coming to tonometry, instrument uses tonometer, with the help of which we can record the accurate IOP. We can take the readings in millimeters of mercury with the help of tonometer. So basically we classify them into 2. One is the indentation tonometry, where we indent the cornea with the help of the tonometer. We put it on the center of the cornea and indent the cornea, and the tonometer is going to give you a reading depending on how much the displacement of the aqueous is there by indentation. Second is applanation tonometry, where we just flatten and applanate the cornea. We don't indent it much. We just applanate the cornea and record the IOP. This prototype of indentation is Saroj tonometer. Okay, I'll tell you what this is. The Saroj tonometer. Okay, this is the foot plate which will rest on the center of the cornea, and based on the intraocular pressure, this point is going to move on this scale and going to give a reading in the numbers, and we have to multiply this number with this chart given with the tonometer. Suppose this is 4, then it is 17.3 millimeters of mercury. Okay. So this is the tonometer, but it's again an objective method of measuring IOP, but it indents the cornea. There are weights which are applied here over the cornea to record repeated IOPs by putting the weight of 5.5, 7.5, 10 milligram of weight. But the issue with this tonometer is that if the eyeball is rigid, it is high, then it will record a false high IOP. If it is soft, then it will record low IOP. Like in myope, the rigidity is less, in hypermetrope it is more. Okay. So it depends on the ocular rigidity, how much the rigidity is there in the cornea sclera, like in high myope or in the high hypermetrope. So it does not give very accurate reading. Tonometer. So more accurate are appellation tonometers, which appellate means just flattens the cornea center, it does not indent the cornea. Okay. Flattens the cornea. So now there are 2 types. One is contact tonometer, means you are touching the cornea. Non-contact means you are not touching the cornea. Okay. These are 2 types of tonometer. So in non-contact tonometer is the air puff which is used to applanate the cornea. So there is a puff of air which comes from the machine and just applanates the cornea and goes back. Okay. Amount of force required to applanate is recorded as intraocular pressure. Okay. What is the advantage of non-contact tonometers over contact tonometers? Advantage of non-contact tonometers? Sorry? Sterile, yes. You may be spreading, when you are screening the patients for glaucoma, like I told you in OPDs, there are 350 patients, you want to take IOP of every patient, you cannot do contact tonometry, you will be spreading infection. There is no time to disinfect the instrument in between. So here we use a non-contact tonometer, where just air puff is used and we record the IOP. So for screening purpose it can be used, but not for patients of glaucoma where we want an accurate IOP. They are not very accurate. Okay. So non-contact tonometry is important in screening of the patient for glaucoma, where you get a IOP. Suppose screening NCT gives IOP 28, then we do the contact tonometry to confirm the IOP. Okay. So non-contact contact tonometer, there are 2 types. Contact tonometer probe is going to touch the cornea. So there is risk of spread of infection. So done in selected patients of glaucoma, where you are suspecting glaucoma. Goldman appellation tonometer is the gold standard, which gives the accurate reading. So in every patient of glaucoma, you always do Goldman appellation tonometry, always. Okay. Then comes the Perkins, which is a handheld tonometer. This is a slit lamp mounted tonometer. Goldman is a slit lamp mounted, means patient has to sit on the slit lamp to record IOP. Okay. So in children you cannot record IOP. Patient who cannot sit on the slit lamp, bedside patient you cannot record with Goldman application tonometer, which is a gold standard. So this is a handheld tonometer also, known as Perkins handheld tonometer, which is handheld. So we can record in children, in lying down posture, and the GA also we can record IOP. That's the advantage of the handheld application tonometer, and the tonopen is also a handheld application tonometer. Non-contact can again be a table mounted or can be a handheld, or for using in pediatric patients or in patients, lying down patients. So coming to one by one, the various tonometers. Now this is the Goldman application tonometer. This is the tonometer. This is the head of the tonometer, which has a prism, biprism, and here lies the dial from where we rotate and we take the reading from here. Okay. This is mounted on the slit lamp. Patient has to sit on the slit lamp. This is the head of the tonometer, which has a biprism, and it will touch the cornea, and we see through the slit lamp microscope to see the Myers, and we record the IOP by taking the reading from here multiplied by 10. Suppose it is 2, then IOP will be 20 millimeters of mercury. So you have to apply the weight 1 gram, 1.5, 2 gram to applanate the cornea, okay, and then we multiply it by 10, it will give us the reading. So what is the principle of Goldman application tonometer? So it is called the Amber-Fick law. The principle of Goldman application tonometer, how it works. Okay, it's a gold standard tonometer used in every patient of glaucoma. Okay, we always record with this only. So this law says that pressure inside a sphere, any sphere, is equal to the force applied divided by area which is applanated. How much force, how much weight you are applying? I told you we apply the weight over the tonometer with the help of a tonometer by rotating the knob. Okay, so force applied to applanate the standard area of the cornea, this will give the IOP, and the area which is applanated with the help of a tonometer over the cornea is 3.06 millimeters, this standard, and the weight we have to see the reading from the dial is 1, 2, 3 or 1.5 multiplied by 10 is going to give the readings in the millimeters of mercury. Okay, that is how we record the intraocular pressure. So like this is the tonometer, so we will applanate the cornea with the help of the weight applied from here. So this will apply the weight here, multiply by 10, this will give the reading, and area applanated is 3.06 millimeter of the mercury. This is the weight. So how it is done? We have to anesthetize the cornea first, because we know contact procedure. Non-contact we do not need to apply an anesthetic, topical anesthetic drop. Okay, so we have to apply the topical anesthesia so as to anesthetize the cornea. We are going to touch the cornea. Then we are put the fluorescein dye to stain the tear film. You know, fluorescein dye to stain the tear, because you want to see the Myers, okay, to record the IOP. So what we do? We put the fluorescein dye so as to stain the tear film. Then we use cobalt blue filter in the slit lamp so as to see those Myers, okay, and then we will see these, what we see through the slit lamp microscope. We will see these Myers over the surface of the cornea, because the biprism, so we see two semicircles on the cornea, and we have to, by moving the dial, we have to coincide these two Myers. This is the ideal position where inner border of the two Myers will touch each other. At this point we will take the reading of the tonometer. Okay. So if it is very thin Myers or very thick Myers, we won't take the reading. Okay. So this is how we record the intraocular pressure with the help of a Goldman application tonometer. We have to put a fluorescein dye, anesthetize the cornea, and then touch the cornea with the help of that biprism, head of the prism, and take the reading by applying the force and joining these two. I told you that is slit lamp mounted. So patient has to sit on the slit lamp, and patient has to be very cooperative for this. Now in patients who cannot sit on the slit lamp, we can use a handheld application tonometer known as Perkins, works on the same principle. The difference that is a handheld, this is the same prism head which is there, this will rest on the forehead, and from here we will move and we will take the reading, will come on the screen directly. It is a handheld application tonometer used for pediatric patients. Pediatric glaucoma, we have to record intraocular pressure. We cannot use the Goldman application tonometer. So we have to use the Perkins handheld tonometer to record IOP in patients who cannot sit on the slit lamp or in pediatric patients. This is another tonometer which is handheld. Advantage of this tonopen is that the area which is in contact with the cornea is very less, 1.5 millimeter. Okay. So here the advantage of this tonometer, tonopen, which is again a handheld application tonometer, the area of contact is very small. So in patients with scarred corneas, there is a corneal opacity. So the Goldman application tonometer Perkins will not going to work, because 3.06 area is applanated. Okay. So patient has a scarred cornea, corneal opacity in the center, we cannot use Goldman or Perkins, because scarred cornea will not give a accurate reading. Okay. But with the help of tonopen, since the area is very small, so we can put the tonometer on the periphery cornea which is clear. Correct? That is the advantage of tonopen. So in patients with scarred corneas, where is a corneal opacity is there, cornea is irregular, the Goldman is not going to give an accurate reading. We have to use this tono pen because the area is very small, so we can put in the area where the cornea is clear and take the reading. Clear? There is advantage of tono pen tonometer. So this will give in reading here again on the screen, just touch this portion and we take the reading. Advantage used in patients with corneal opacities, where Goldman will not give you accurate reading because you have to apply it in the center 3.06 millimeter. So this is central corneal opacity, we cannot take the reading. A cornea is very irregular, match will be irregular, okay. But here it's very small, so we can put in the area where the cornea is clear and take the reading. That is the advantage of this tonometer. Coming to non-contact, where there is no need of local anesthesia, can be used as screening purpose in OPD, like we have in our OPD NCT, every patient undergoes NCT to rule out glaucoma. So here patient has to put the chin here, is the forehead rest, and this screen is going to give us the reading. It will give the thickness also, it has both the functions, corneal thickness as well as the intraocular pressure, okay. So just you have to press from here and center over the center of the cornea and press it, it will release a puff of air which is going to applanate the cornea. Amount of pressure required to applanate the cornea is recorded by the tonometer. It gives a reading which is a rough estimate of intraocular pressure, okay. It does not give very accurate, so if it gives higher reading we have to confirm with the help of a Goldman applanation tonometer. This I told you, handle applanation tonometer, non-contact pulse air. So here we can use in patients, pediatric patients or patients who cannot sit on this on the table and cannot, we can use the the NCT, we use the pulse air, it is a handheld tonometer. Another is eye care rebound tonometer, which is, there is a probe here. Again this does not require a local anesthetic because the probe size is very small. So we just have to, this probe is going to touch the cornea, will rebound back and machine is going to give us the reading. So this is a very easy to do, no need of anesthetist because it's a very small probe which will come out and will touch the cornea, rebounds back and gives the reading depending on the eye intraocular pressure. There is another model which is a home tonometer. Patient can record his tonometer pressure at home. Okay, it's very easy, home tonometer eye care, which is placed like this and patient will just press the button and the probe will come and will go back. And it's a very small, so no need of local anesthesia also. So home tonometry can be done. We want to do a diurnal variation. Okay, patient cannot come for intraocular pressure measurement regularly. So we can tell the patient to record pressure at home, known as home tonometry, eye care home tonometer. So there are various types of tonometers are there to record intraocular pressure, but what is used commonly is Goldman applanation tonometer. Remember this, there is a gold standard. And in glaucoma we always rely on Goldman applanation tonometer because that gives an accurate reading. Okay. In children we use tono pen. Scarred corneas we use tono pen, okay, to record the intraocular pressure. These are the two tonometers which commonly used which gives the accurate readings. Okay. This was about the tonometry, and I told you besides this we have to do the central corneal thickness in every patient to know the accurate. This is whatever we recording is accurate or it is not an accurate IOP. So always do CCT along with the intraocular pressure measurement. Coming to second investigation, so when we record IOP, then we go for gonioscopy. We never do gonioscopy first and then IOP. Why? Why? Gonioscopy done by putting a lens over the cornea, okay, and then we see the angle in various quadrants. So always we do tonometry first, followed by gonioscopy, then we dilate and do disc evaluation, then send patient for perimetry. This is the order which we follow. Okay. So we are not supposed to touch or press the globe before doing tonometry. Okay. So if you do gonioscopy first, indent, press the cornea and touch the cornea and do the gonioscopy, then record IOP, you may be recording a false eye because repeated indentation can lower the intraocular pressure. Okay. So always do tonometry first, then gonioscopy, and then we dilate to see the disc evaluation. Okay. So gonioscopy to examine the, what is the purpose of gonioscopy? Angle of anterior chamber. Why I want to say angle of anterior chamber? To classify glaucoma. Primary है, secondary है, angle closure है, open angle है. Secondary you may find some pathology in the angle. Okay. So what is the principle of gonioscope? Normally by throwing torchlight you cannot see the angle, okay, because these rays which are going to the torch will goes under total internal reflection. So we have to put the gonioscope over the cornea, replacing the air cornea interface with the lens cornea interface. So these rays which are thrown here will come out and we can see the image of the angle, known as gonioscope. We placed over the cornea and we see over the slit lamp the angle of the anterior chamber. So the principle is that whatever light is thrown in the angle, it comes back. It is a total internal reflection normally. We cannot see with a torchlight. So we have to put a tonometer so as to light gets reflected outside and we can examine the angle of anterior chamber. So there are various types of gonio lenses are there, direct, indirect. Direct means you are directly visualizing the angle, means you are looking at 12 o'clock, you are seeing 12 o'clock angle. You are seeing 6 o'clock, you are seeing 6 o'clock angle. Whereas the angle is, the gonioscope is placed. Indirect, we see a reflected image, means the mirror is at 12 o'clock, we are seeing angle at 6 o'clock, because we are giving an image of the angle. So there are mirrors or prisms are there inside the gonio lens, indirect gonio lenses. So if you put a lens at 12 o'clock, then you see the angle at 6 o'clock, or you are seeing through the lens at 12 o'clock, you are seeing angle at 6 o'clock. So you have to rotate in all the directions to see the various angles. So direct and indirect gonio lenses are there. These are the various lenses which are used, indirect and direct gonio lenses. You need not to remember all the names. Okay. So what are the structures seen in the angle? So when you are seeing angle, what you want to see? What you are seeing in the angle on basis of which you are going to classify it as angle closure and open angle glaucoma. Correct. So structure seen in the angle. So I told it between the cornea and the iris. There is a dome of the cornea, there is the eye root of the iris. Here lies the recess, which is the angle of antechamber. So what do you see from anterior to posterior? First structure seen is the Schwalbe's line. So what is Schwalbe's line? It is nothing but the end of the Descemet's membrane, end of the cornea. So it's seen as a white band, white ridge. It is the end of the cornea which you are seeing, starting from the corneal side. The Schwalbe's line is nothing but the end of the cornea or end of the Descemet's membrane. It's seen as a white band in the angle. So when you start see, this is the iris, this is the cornea. Okay. So we start seeing from here, first white band which is seen is the Schwalbe's line, correct. Second structure which you see is the trabecular meshwork, pigmented band. Okay. We see another structure, trabecular meshwork in the angle, which looks like a pigmented dark brown band is seen. Okay. So first will be a white band which is known as Schwalbe's line, which is end of the cornea. Second, what you see is the pigmented band which is known as trabecular meshwork. Then you see the again a white band known as scleral spur, end of the sclera, which is projected into the cornea to which the ciliary body, longitudinal fibers of ciliary body are attached. And then comes the ciliary body at the root of the iris, then the root of the iris. Okay. This is structure which we see in the angle of antechamber, starting from first corneal side, Schwalbe's line, which is the end of the cornea or the end of the Descemet's membrane, seen as a white band in the angle. Then comes the trabecular meshwork, which is a pigmented line we see. Okay. Trabeculum which we are seeing. Then comes the spur, so again a white line is seen. And then comes the root of the, ciliary body band, which is again a dark brown color band, and then comes the root of the iris. These are the four structures which we see in the angle. You can remember as ST, SC. Okay. So Schwalbe's line, trabecular meshwork, scleral spur and ciliary body. These are the four structures, two dark bands and two white lines. Clear? Okay. The four structures we see in the angle of antechamber. If the all four are seen, means the angle is wide open. So if you put a gonio lens and try and see the structures, if you see all four structures, two white bands and two brown bands, it means all four are seen, starting from Schwalbe's line to ciliary body band, it means the angle is wide open, correct. And no any abnormality seen means the angle is normal, but it is a wide open angle, around 35 to 45 degrees open, correct. So this is how it looks on gonioscopy. A gonioscope mirror is placed over the cornea. We see the root of the iris, pupil, and this is the cornea which we see. Now, this is the angle which is seen. Now, here it is a wide open angle. You can see the white line, okay, the Schwalbe's line, then comes the brown band, this is the trabecular meshwork, another light, this is the scleral spur, and this brown is the ciliary body band. Okay. So, with these four structure, two white and two brown layers, okay, they are the four structure we see in the gonioscope lens. Okay. So, if the lens has a 4 mirrors, 1, 2, 3, 4, then you just have to place the lens and we can see all the 4 angles at one time. Okay. Superior, inferior, nasal and temporal, 4 angles you have to see. So, if the lens has 4 mirrors in it at 12, 6, 3 and 9, then we can visualize all the angle together at one time. It is a 2 mirror lens, then there are 2 mirrors, 12 and 6 o'clock. So, first you will see 12, 6 angle, then rotate the lens, then see 3 and 9 o'clock. Okay. They can be single mirror also, we have to rotate in all 4 quadrants. So, 1 mirror, 2 mirror, 4 mirror lenses are available. These are contact lenses, you have to put the lens over the cornea and then in the slit lamp examine the angle one by one all 4 quadrants to see whether the angle is open, means all structure are visible, or they are not visible, or how many structures are visible. So, we grade the angle according to number of structures visible in the angle and we see any abnormality in the angle, okay, like it could be hyperpigmented angle. Okay, there may be some new vessels may be seen in the angle, there may be some abnormality in the angle may be there, could be cause of secondary glaucoma. Okay. So, there is the importance of gonioscopy in every patient we have to do. So, there are various grading systems are there to grade the angle. Right? So, when you do gonioscopy, you have to write your interpretation, whether this angle is open, it is grade 4, grade 3, grade 2, grade 1, it is narrow, totally 0 angle. So, there are various grading systems are there to grade the angle. to write the result of gonioscopy. So this is Schaeffer's grading system, which is most commonly used. Schaeffer's grading system, in which grade 4 is the widest angle, means all 4 structure visible. So if you see in gonioscopy up to ciliary body band, means all 4 structure visible. So you get is a wide open angle. So it's a grade 4 angle, approximately around 35 to 45 degrees the opening, and we call it as a grade 4 or wide open or widest angle. So it has to be case of a primary open angle glaucoma. High IOP with gonioscopy you do. So you find that all 4 structures seen up to ciliary body band, means open angle hai, it has to be open angle glaucoma. Okay, and no any abnormality seen, so it has to be primary open angle glaucoma. Okay, then grade 3 is only 3 structures are visible. So what is not visible now? Ciliary body band is not visible. Okay, so you see only the trabecular meshwork, slush spur and the Schwall baseline. 3 structure visible. The angle is now narrowed down, so ciliary body band is not visible. It means it's a grade 3 angle. Still trabecular meshwork is visible, so it's a open angle. It's a open angle. It's a wide open angle. So grade 3 means 3 structures seen up to slush spur seen. Ciliary body band is not seen, but still you are seeing spur and trabecular meshwork and Schwall baseline. So it's a grade 3 angle, which is again open angle because meshwork is still visible. So it's a open angle. Okay. Grade 2 is moderately narrow angle. Okay. Now spur is also not visible, only part of meshwork and the Schwall baseline are visible. So it's a grade 2 angle, so moderately narrow angle, the risk of angle closure glaucoma is there. Okay. And grade 1 is nothing is visible, only you can see a white line, the Schwall baseline. So now the meshwork is also not visible, so it's a very narrow angle, chance of angle closure glaucoma is very high because meshwork is also not open. Okay. So patient may have a angle closure glaucoma, so we label it as a angle closure glaucoma suspect. Right, we label these patients as suspect because he is going to have a anytime attack of angle closure glaucoma because the meshwork is also not visible. So from where the aqueous will be drained. Okay. So this angle, grade 1 angle, is the risk of angle closure glaucoma. So label them as suspect and we keep them under observation and take a history of attacks also. Okay. How we take the history of attacks? Patient will have a pain, headache, halos because of attack of rise IOP. Okay. So we have to take a history of any headache, pain in eye, halos, blurred vision, and these are the patients who have a higher risk of angle closure. So we label as suspect and we keep them under follow up. Correct? So this is how we grade the angle. If nothing is visible, even Schwall is not seen, then it is known as a slit angle. We see a opening recess, but there is no structure visible. There is a recess seen between the root of the iris and cornea, but no structure visible. But there is no contact, called a slit angle, where risk of enclosure is very high because nothing is visible, or there can be contact between the two, iris in contact with the periphery of cornea, known as zero angle. Correct? So grade 0 is when there is a iridocorneal contact is there. So can you see this structure? Here nothing is visible. I showed you the diagram in all 4 structure visible. Okay. Now in this diagram nothing is visible. You cannot see anything. Can you see any structure in the angle? Nothing is visible in this angle. Whereas this angle I showed you, all the structures were visible. Can you see? Okay. On gonioscopy all structures are seen, wide open angle, but if you see this diagram, nothing is visible. You cannot see anything in the angle. So it's a narrow angle. It's a grade 0 angle. Okay. So it's a closed angle because there is a iridocorneal contact is there. Now this contact can be a adhesion, it can be just a oppositional contact. Okay. There are 2 types. One is they are just in contact with each other. One is there is a adherence known as synechial closure. So if the patient had an attack of angle closure glaucoma, there will be inflammation in the trabecular meshwork and there will be adhesion between the 2, cornea and the root of the iris, known as iridocorneal contact, and that is known as a synechial closure. Okay. So angle is closed because of adhesion between the 2. So now it will not open up, patient will have a constantly high IOP. Is it clear? Okay. So if the angle is structure are not seen and you see iridocorneal contact is there in gonioscopy, so it can be a positional closure where they are just in contact but there is no adhesions because patient did not have any attack of angle closure glaucoma, or there can be a synechial closure. Okay. The adhesions. So how will you differentiate between these 2? The 0 angle iridocorneal contact is there, but is oppositional or synechial closure. How will you differentiate between these 2? So there is a gonioscopy called a indentation gonioscopy, where you indent the cornea with the help of gonioscope. So what will happen? You are pushing the aqueous in the angle. You are indenting the cornea, center of the cornea with the help of a gonioscope. You are pushing the cornea inside, so you are displacing the aqueous humor in the angle. Correct? So if it is a oppositional closure, then it will open up. Okay. If you do indentation gonioscope, indent the cornea with the help of gonioscope, pushing the aqueous towards the angle. So what will happen? Because of the flow of the aqueous, pushing the aqueous in the angle, it will open up its oppositional closure. The cynical closure, it will not open up. So when you do indentation gonioscopy, you are going to start seeing structure if it is oppositional closure. It means patient didn't have any attack of angle closure, it is still suspect. Okay? But if it doesn't open up, it means there is a adhesion. So you have to see in all 4 quadrants this, and you have to label where indentation gonioscopy opened the angle or it remained closed. That will tell you patient has cynical closure is a sign of previous attack of angle closure, means patient has already had an attack of angle closure glaucoma, so it is a patient of primary angle closure now. Oppositional means patient has a risk of angle closure, it is a suspect. Clear? That is the importance of gonioscopy, to differentiate between angle closure and open angle, and to know angle closure whether the patient is suspect or had an attack of, because patient may come after the attack. So IOP may be normal, a single attack, so no changes in the optic nerve head also. Okay, no optic neuropathy because had only single attack or 2 attacks of high IOP, so may not have changes in the optic nerve head. IOP may be normal. So how will you diagnose? Both are normal by gonioscopy. Do gonioscopy and see what is status of the angle. Okay, that is how you diagnose angle closure glaucoma, by doing gonioscopy, because patient may come in between the attack when IOP is normal, and single attack will not give rise to any change in the optic nerve head, no optic neuropathy. Correct? So patient may have both normal, but if you do gonioscopy, you can find out the patient had an attack of angle closure. So you take a history and ask the patient, you had any time headache with pain in eye, with blurred vision, with halos around the light. So patient may say, yes, I have this frequently. And gonioscopy shows the synechia, peripheral anterior synechia they are called. So you can diagnose with the help of, with the history and with the help of gonioscopy angle closure glaucoma. Is it clear? Okay. So I was telling you about Schaeffer's grading system. So there are various grades of angle where all 4 structures are seen. Grade 0 is where the no structure are seen. Only Schwalbe's line is grade 1, Schwalbe's with TM is grade 2, up to spur is grade 3 and 4, means all structures are seen. So you can grade the angle and always document it. Here you can see all 4 structures are seen, the white band, the brown band, white and again brown band, all 4 structures are seen. Okay. You can see this here also, you can see the ciliary body band. These are what? Can you see tenting of the iris? Can you see this tenting of the iris in the angle? These are small, these are called goniosynechia. Adhesions, I was telling you about adhesions. So these are the goniosynechia where you can see the iris is adherent to the trabecular meshwork. So this is because of the angle closure, attack of angle closure. So angle gets closed, then IOP goes down, then again it does not open because of the adhesions, it remains there only. Okay, known as synechia. Peripheral anterior synechia or goniosynechia, you can see this tenting of the angle. Here there is no tenting. Okay. Here you can see the adhesions of the iris over the trabecular meshwork, known as goniosynechia or peripheral anterior synechia. It is a sign of previous attack of angle closure glaucoma. So gonioscopy is very important investigation to classify and to see the staging of the glaucoma also, the angle closure glaucoma especially. Okay. So gonioscopy has to be done in every patient of glaucoma, whether it is open angle glaucoma or angle closure glaucoma. Okay, so this was about the gonioscopy, okay, where we differentiate primary and secondary also. I will tell you what are the features in secondary angle closure open angle glaucoma. Okay, this is about the primary where only you see the structures or you see the synechia. No any abnormality seen, any abnormal structure is not seen in the angle. So that is the how we do gonioscopy with the help of a gonioscope lens. I told you direct and indirect. Direct usually you use in when there are many surgeries that are done in the angle also, angle surgeries which are called. There we use a direct lens. We place a lens at 12 o'clock, we have to want to see the angle at 12 o'clock only. Whereas indirect are used in OPD usually, where we put a lens at 12 o'clock and we see the angle at 6 o'clock. Okay. So direct indirect gonio lenses and gonioscopy to grade the angle, grade 4, 3, 2, 1, to know what is the status of the angle in angle closure glaucoma. Okay. Coming to optic nerve head evaluation, I told this is the most important thing where we can diagnose glaucoma at earliest. IOP may be normal in your OPD, patient may have peaks in the evening or morning, but if you see the disc, evaluate disc properly, you can always diagnose a suspect glaucoma on the typical changes seen at the disc in patients with glaucoma. So I told you this is the optic nerve head where all the fibers are passing, retinal nerve fibers are passing, and nerve fibers are axons of ganglionic cells. Okay. So these axons which are passing through this optic nerve head, they are damaged here. So we see typical changes in disc and around the disc in glaucoma, peripapillary area and disc, the 2 important structures were to be examined in every patient of glaucoma. Okay. So how do we examine? What are the instruments to examine the optic nerve head? Okay. What are the various instruments to examine the optic nerve head? So you must have heard about the direct ophthalmoscope. Okay. You must have seen also direct ophthalmoscope, Then we have this indirect ophthalmoscope, which is head mounted, and there is a lens used along with this, and then we see the fundus or the optic disc. Then these are the high power lenses, 90D and 70D spherical lenses, which are used along with the slit lamp to examine the disc. So, there are various techniques. Now, which one is the ideal, which one is the best, okay, which should be used ideally to examine the optic nerve head in glaucoma. Okay. So, this direct ophthalmoscope gives a, we see with one eye only. So, there is no stereopsis. Okay. With direct ophthalmoscope it gives a good magnification, around 15 times magnification, good illumination also, okay, but it gives only we see with one eye, does not give a stereoscopic view, depth perception is not there. Okay. So, you want to see thinning of the rim, you cannot appreciate it because it is a monocular. Okay. So, this is not used for disc evaluation in glaucoma except in children. Those who cannot sit on the slit lamp, where we use these lenses, we depend on direct ophthalmoscope, or patient who cannot sit, we have to use the direct ophthalmoscope, we depend on that only. Okay. Suppose you want to do a child with glaucoma examination under anesthesia, so you have to use direct ophthalmoscope, okay, because for these lenses patient has to sit on the slit lamp. Indirect can also be used, that also can be used for fundus examination. This is binocular, but magnification is very less, 5 times only. So, we cannot see the details of the disc, we can evaluate every minor point of the disc, how the changes occurred. So, direct gives good magnification, good illumination, but no stereoscope. This gives good illumination, binocularity also there, but magnification is very less. We want to see a magnified view of the disc to see the salient features. Okay. So, this is also not used except I told you in patients who where we cannot use this. These are the lenses which are ideal for disc evaluations in glaucoma. Okay. These are the lenses which are used on the slit lamp. Patient has to sit on the slit lamp, we put this lens in front of the eye and see through the slit lamp. Gives a good illumination, good magnification, good stereopsis also. So, this is the ideal technique known as slit lamp biomicroscopy. It is called slit lamp biomicroscopy using these lenses, 78, 90 or 60 diopter lenses are there. They are high spherical lenses which gives a good magnification. Slit lamp gives a good illumination and gives a good stereopsis also because being binocularly. But for this patient has to sit on the slit lamp, correct. So, this is the, if you ask what is the technique to do disc evaluation in glaucoma, we always use this. Okay. But these can be used provided patient cannot sit on the slit lamp or we have to do a bedside examination or in children under GA. They are children pediatric glaucoma patient, we have to depend on this or this. But this is the ideal technique to examine the optic nerve head. Alright, this is the ideal technique because it gives a good magnification, illumination and good stereopsis also. We want to see the salient features. So, again what is optic disc? I told you in the beginning, what is optic disc? Optic disc is nothing but a conduit for the retinal nerve fibers which are leaving the eye. All the nerve fibers, nerve fiber layer of the retina, the axons and ganglions which are leaving the eyeball through this conduit in the sclera is called the optic disc, which we examine in glaucoma. So, it is a normal disc is vertically oval. The size is varies from 1.5 to 2.2 millimeter, bigger in myope because they have a longer bigger eye, smaller in hypermetropes. Okay. So, this is a normal disc appearance, a pink looking disc, vertically oval, 1.5 to 2.2 millimeter in size, and the size may vary. Size is very important in glaucoma, it is a large disc or a small disc or an average size disc. So, okay. This is a normal optic disc which we have to examine. I told you last time what is lamina cribrosa, thin sieve like structure which is there at the optic disc through which the nerve fiber is going to pass to form the optic nerve. This is the structure of lamina cribrosa, okay, which is network of collagen fibers of the sclera here from where all the axons are passing, 1.2 million axons are there which are passing through the lamina cribrosa to form the optic nerve, and changes are seen here at this area only. Okay. This is lamina cribrosa, you can see the pores are bigger here and they are less supported. So, we mostly see changes at the poles of the disc, superior inferior pole. In glaucoma what we see changes see more at the poles, superior inferior pole here and here because they are less supported by the lamina cribrosa, pores are bigger. So, they are early to get damaged in glaucoma. So, mainly we see changes at the superior inferior pole, okay, of the optic disc here, and this is lamina cribrosa to the sieve like structure through which the fibers are passing. So, lamina cribrosa in the center and these are the fibers which are passing all around from the disc. So, this area is called the nerve, the neuroretinal rim, this area from where the fibers are passing, okay, and this center is called the cup which is the pale looks. Why it looks pale in color? The center of the disc which is called cup or depressed area. Why it is called cup or what it looks pale in color? because there are no fibers passing from there, or the fibers distributed at the periphery. Okay. So, these fibers are, the center part is known as cup and peripheral part is known as neurotubular rim and peripapillary area. So, we are going to examine this part in patients with glaucoma. So, this I will deal in the next class. Okay. What are the changes we see in glaucoma? So, today I told you about tonometry, how to record IOP and how to examine the optic nerve head. आया नहीं है. Any questions so far? Can you give me a paper and a pen? Nobody has come to take the attendance today. Please give me a paper and a pen. So, any questions? Can you give me a, so I will just take the attendance. So, any questions so far?
Seven, 8, 9, 10, 11, 12,
11 absent.
13,
12 absent. 12 absent.
14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28,
28,
29, 30, 31, 32, 33, 34, 35, 36, 37, 38, 39, 40, 41, 42, 43, 44, 45, 46, 47, 48, 49, 50, 51, 52, 53, 54, 55, 56, 57, 58, 59, 60, 61, 62,
absent.
60, 64, 65, 66, 67, 68, 69, 70, 71, 72, 73, 74, 75, 76, 77, 78, 79, 80, 81, 82, 83, 84, 85, 86, 87, 88, 89, 90, 91, 92, 93, 94, 95, 96, 97, 98, 99, 100, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25.
That's all. Write on time 9 to 10. Date. Absence. Name. My name. My name also here. And give me the paper. Yes? 20? 21 batch. 21 batch का भी लिखो. Write on here. This is batch 20. Batch, write batch also. Here. 21 batch. Write 21 batch.
22.
No, here write 20. There are students from 21.
That's
Roll number?